Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The cardiology seminars are brought to you by Triple N Media. Our YouTube channel has more than 200 cardiology lectures. You're welcome to watch them, and also please do subscribe to our YouTube channel. I also have a cardiology rotations manual which is useful for students, residents, nurses, and for cardiology fellows during your cardiology rotation. It has more than 175 pages of useful information. I will tell you how you can get a free copy of this book at the end of this presentation. The feature presentation today is aortic stenosis, low gradient, low outflow or flow, low ejection fraction or normal ejection fraction. How do we determine who needs medical treatment, who needs follow-up, who needs surgical treatment or TAVR? So let us begin with the feature presentation. In order to understand this hemodynamics as what is happening in a patient with aortic stenosis is based on many factors, the most important of which are the aortic valve structure. The aortic valve may be normal, there may be some fusion of the commissures, or there should be some calcification and nodules. Or in a worse scenario, there may be heavy calcification with narrowing of the leaflets with very small slit-like opening. And as you can see here is a fusion of the cusps. So the structure of the valve is important. And the degree of calcification is also an important factor, which I'm going to touch upon towards the end of the presentation. So that determines whether this patient has true aortic stenosis, that is an aortic valve area of less than 1 centimeter square or less than 0.6 centimeter per square meter body surface area. So let's keep that in mind. So that is as far as the structure is concerned. The next thing is left ventricular pressure generation. Aortic stenosis is a narrowing of the aortic valve, as a result of which the ventricle has to pump with greater force to get the blood through the stenotic valve. So the velocity with which the ventricle contracts, generating a significantly higher pressure to get adequate stroke volume through the stenotic valve, determines the gradient. If the ventricular function is reduced, if the ventricle is dilated, and if the stroke volume is low, that can lead to reduced flow going across the aortic valve, creating a false low gradient. In patients with hypertrophic cardiomyopathy who have concentric left ventricular hypertrophy, their cavity sizes are extremely small. So the stroke volume ejected, even if normal contraction, may be less than ideal to maintain proper cardiac output in patients with critical or moderate aortic stenosis. So there are a lot of things that are interplaying in patients with aortic stenosis, depending upon the structure, the thickness of the ventricle, the force generated by the left ventricular cavity, left ventricular ejection fraction, and also left ventricular end-diastolic volume in patients with advanced heart failure who may have large volume, but if their ejection fraction is 20%, the amount of blood pushed through the valve may be very small, plus the pressure generated may be exceedingly not enough to get the blood across. So there are a lot of things that we need to determine, and the real question comes as, okay, which patient can benefit by aortic valve repair, aortic valve replacement through surgical means or through TAVR? That's the main question. Is there an adequate left ventricular function that might get better with valve replacement, or the ventricular function is so limited, replacing the valve may not significantly change the clinical outcomes, or what we are seeing, this low gradient, maybe what it is just pseudo aortic stenosis. Okay, let's find out how we are going to determine all these different scenarios. And here is a sort of a visualization of what I was talking about. In a normal ventricle, the ventricular cavity is normal, the ventricular thickness is normal, the pressure generated is normal. So if you have a normal heart with a normal ejection fraction, then the gradient we're going to see is probably a true reflection of the aortic gradient across the outflow tract. Whereas in patients with dilated cardiomyopathy, where the stroke volume is very low, the pressure generated is low, when the systolic pressure is like 100, 120 or 80 millimeters of mercury, you don't have enough pressure to get the blood across the valve, so the gradient could be low in these cases. And we need to determine whether the gradient truly reflects critical aortic stenosis or whether it's due to low stroke volume and low cardiac output. Whereas in hypertrophic cardiomyopathy, as I mentioned to you in the previous slide, there is increased thickness of the ventricle. The systolic function may look like it is normal, but the stroke volume may be inadequate to maintain good cardiac output in the presence of aortic stenosis. Now we have to determine whether the aortic stenosis is true or whether it is just related to the function. Here is something we can do in patients with low flow, low gradient aortic stenosis. Let's take, for example, we have an aortic valve area of less than 1 centimeter per square or 0.6 centimeter per meter square body surface area, and a mean gradient of less than 40 millimeters of mercury with a preserved ejection fraction of 50%, but a stroke volume of less than 35 ml per meter square. That's the hypertrophic type, which I showed you in this previous slide, something like this. So what are we going to do? First of all, confirm your measurements. So just don't rely upon one study. Maybe repeat a study and get different views and see what are the maximum numbers that can reflect the true aortic valve area. Maybe combine them with three-dimensional echocardiography or any other features that might be helping to determine the structure of the valve. Okay, after we have done the second test, is the patient having symptoms? If the person is not having symptoms or equivocal symptoms, we can follow these patients, we can do an exercise test, and if the exercise test is abnormal, then is this patient having hypertension? That's an important thing to keep in mind. The increase in afterload can increase the work the heart has to do, which can alter the gradient. So adequate control of blood pressure is the next step. Once we have done that, the next step is to determine the severity of the aortic valve's narrowing. This can be done using multiple approaches, the most significant of which is dobutamine stress echocardiography, or DSE for abbreviation, and of course MDCT, multi-detector CT of the heart, looking for aortic valve calcification. Based on that, we can determine as which category does this patient belong, which will be covered in the next slide. If the stenosis is true aortic stenosis, then you consider these patients for surgical or percutaneous aortic valve replacement. Okay, let's begin with the dobutamine stress echocardiography. When these patients are subjected to dobutamine stress echocardiography, getting the dobutamine up to 20 micrograms per kg per minute, if we can increase the stroke volume by 20%, and if the gradient goes above 4 meters per second, and if the aortic valve area remains less than 1 centimeter square, then we are dealing with true severe aortic stenosis. And these patients may benefit from surgical or transcatheter aortic valve replacement. Let me repeat this again. This is the group of patients where we are looking at a left ventricular ejection fraction of less than 50%. So we have low flow, low gradient, and low ejection fraction. Dobutamine stress echo. If the stroke volume goes up by 20%, if the gradient goes up more than 4 meters per second, then you are dealing with true aortic stenosis. On the other hand, when you subject these patients with low ejection fraction, low flow, low gradient to dobutamine stress test, and the gradient does not go beyond 4 meters per second, the aortic valve area increases to more than 1 centimeter per second, then you are dealing with pseudo-severe aortic stenosis. So we need to focus upon heart failure treatment. On the other hand, if the stroke volume is less than 20% increase, if the aortic stenosis severity is intermediate based upon the echocardiography and structural evaluation, the second parameter that we can use is calcium score of the aortic valve region. If it's less than 1200, we are dealing with pseudo-severe aortic stenosis. But if the calcium score is greater than 2000 in the aortic valve region, then we are dealing with true severe aortic stenosis, and these patients may benefit from surgical or transcatheter aortic valve replacement. So let's summarize this again. If the stroke volume is less than 20%, so we are talking about low gradient, low flow, low ejection fraction, dobutamine stress test, the stroke volume goes up by less than 20%. And when the stroke volume is less than 20%, then we proceed to CT calcium score. If it's greater than 2000, then you consider intervention. If it's less than 2000, you treat them for heart failure. And here are the guidelines for aortic valve replacement for low flow, low gradient aortic stenosis. Classical is the low flow, low gradient is reasonable in symptomatic patients with low ejection fraction, low gradient, severe aortic stenosis. If the dobutamine stress increases the gradient to more than 40 millimeters with aortic valve area of less than 2 centimeters, and we already talked about that one. Whereas paradoxical low flow, low gradient, aortic valve is reasonable in symptomatic patients who have low flow, low gradient, severe aortic stenosis, or normotensive and have ejection fraction of greater than 50% if clinical hemodynamic and anatomic data support valve obstruction as the most likely cause. So here are the class 2A and 2A. Let's look at this from a different angle. This is from a different study, but maybe we'll pick up some extra points here. Classical low flow, low gradient aortic stenosis. Mean gradient less than 4 meters. And aortic valve area is the same thing. So dobutamine stress echocardiography up to 20 micrograms per kg per minute. If the stress echo is not feasible or inconclusive, or Q at rest is 250 ml per second, and if we can determine the severity, we go for the calcium scoring, and based upon the calcium scoring, we see what needs to be done. Either we treat them medically for heart failure or treat them with valve repair or replacement. And of course, if the gradient goes up, the valve area gets critical, then it is true aortic stenosis. We proceed with the valve repair or replacement. If the stress gradient is less than 40 and less than 4 meters per second, aortic valve area is less than 0.6, and if you are not sure, then we measure the aortic valve area. If it's less than 1 centimeters, you go for valve replacement. If it's greater than 1 centimeter, of course, pseudo-aortic stenosis, and you follow this pathway. So it kind of helps us to triage these patients. And here is a CT scan of a patient with severe calcific aortic stenosis. This is how it would look. And here is the aorta. There's a lot of calcium in the aortic valve wall also, and there's a lot of calcium on the cusps. And the computer calculates the Agatston's score. Here is an echocardiogram showing a lot of heavy calcification, reduced wall motion, doming of the leaflets with gradient across the aortic valve. This is the same thing, but you can look at it. And here is a case report of a 73-year-old patient with coronary artery bypass surgery, low flow, low gradient aortic stenosis, who also had mitral regurgitation and New York Heart Association class 3. The patient underwent mitral valve repair and then underwent dobutamine stress echocardiography to determine the degree of aortic stenosis. The LV ejection fraction was 30% and an end-diastolic volume of 273 ml. As we can see at the baseline, the stroke volume was 42, which was not bad. The gradient was aortic valve area was a 0.79. It's less than 1. And the gradient was only 28. But at the 20 micrograms per kg per minute dobutamine stress echo, the gradient went up to 42 millimeters. The aortic valve area was less than 1 centimeters, and this is a case of a true aortic stenosis. This patient underwent successful TAVR, and 6 months follow-up was doing well. So this is how we take the physiologic data, hemodynamic data, echocardiographic reports, CT scan, and dobutamine stress echo, put all these results together and come up with a composite analysis of who has pseudo-aortic stenosis, who has true aortic stenosis, and who would benefit from valve replacement or TAVR. Ladies and gentlemen, this seminar has been brought to you by NNN Media. And if you would like to get a copy of my cardiology rotations manual, please send me an email to drniknikam@gmail.com and I'll be happy to send you one. We have more than 200 cardiology lectures on our YouTube channel. You're welcome to read those or watch them. And please do subscribe to our YouTube channel. This has been a presentation of NNN Media. I'm Dr. Nik Nikam, a cardiologist from Houston, Texas. Thank you so much, and please do subscribe to our YouTube channel.